Ladies and gentlemen, welcome to All India Radio Houston. I am Dr. Nik Nikam. During the last half hour, we are talking about Dasra Mela 2014 and Ram Leela. Now we're going to switch gears and talk about recovery from traumatic brain injury among children. My special guest is Dr. Monica Vavilala, a professor of anesthesiology and pediatrics and an adjunct professor in neurological surgery at the University of Washington. Her special interest is in treating traumatic brain injury, especially in the pediatric population, and specifically linking treatment to acute care with long-term outcomes. Traumatic brain injury is an important topic because this can happen to any child under any circumstances, like tripping and falling over from steps, or falling off a swing, or falling off from any play objects, or getting hit by any object, and that may have long lasting repercussions. And so our special guest is going to talk about how we can try to minimize these things. My special guest, as I said, is Monica Vavilala, who is an internationally recognized researcher who focuses on examining changes in systemic hemodynamics, blood flow to the brain, and how brain behaves following a traumatic injury. She received her medical degree and completed pediatrics training at the University of Texas and her residency in anesthesiology from the University of Washington. She works as a researcher at Harbor View Injury Prevention and Research in Seattle, Washington. So she has come all the way from Seattle, Washington, and Dr. Monica Vavilala, welcome to All India Radio. We are delighted to have you.
Thank you very much.
Okay, let's start by telling exactly what you do in Seattle, Washington as a brain injury specialist.
I'm a neuroanesthesiologist at the University of Washington in Seattle.
Yeah.
My practice involves taking care of patients who have traumatic brain injury when they come to the hospital and need procedures to help them. Since I'm part of an academic department, we also have a research component to our practice profile.
Yeah.
So I spend over 50% of my time in research and administration. So I direct the Harborview Injury Prevention and Research Center, which is in Seattle. And that involves directing a group of faculty members who are interested in injury prevention.
I see,
interested in taking care of injured patients and figuring out ways how people can be rehabilitated well and reintegrated after their initial injury.
That's fascinating. You know, I've been a cardiologist. I have not dealt too much with trauma, but even a minor trauma can leave, long-lasting effects not only on the child or the injured, but the entire family.
This is true. We used to think that children who have traumatic brain injury recover really well and really fast, which they often do. But we're only now starting to understand that the disability and impairment that result from TBI can last for years, if not decades, after the injury.
Okay, let's tell us, you said you are an anesthesiologist. How did you get interested in traumatic brain injury to the children?
As you mentioned earlier in my introduction, I completed my medical school and pediatrics residency here at the University of Texas in Houston. And I remember my rotations at the LBJ hospital as a resident. And it always struck me that when the shock trauma buzzer went off, we would receive these injured children with very little histories. And we were supposed to resuscitate them, make them survive. But there were very important questions that we didn't have answers to. For example, what should a normal blood pressure be in a child? What blood pressure translates to adequate blood flow to the brain? And we treated patients assuming these numbers, which were not really based on data.
Scientific data.
And so when I joined the faculty of the University of Washington, I started asking a series of questions such as, what
Yeah.
are the optimal hemodynamics for injured children, and how do those hemodynamics like blood pressure and cardiac output actually translate to adequate cerebral or brain perfusion, that is how much blood flow gets to the brain with those blood pressures after injury. And does that change over time? So there's, in fact, you're a cardiologist, which is really exciting because we've started a new line of investigation linking the brain with the heart in injury. We always think about the brain when patients undergo cardiopulmonary bypass, for example. But think about it the other way. If your brain is injured, we know that the brain normally sends out signals to the heart to control its dynamics. There's a very powerful, balanced, sympathetic, parasympathetic system, and the heart receives inputs from the brain in terms of how much blood to push out. So we just finished a series of studies examining the heart in adult patients who have traumatic brain injury, who did not have any a priori cardiac disease. And this paper is coming out in Critical Care Medicine. We were able to show that there's a 14 to 20% prevalence of cardiac systolic and diastolic dysfunction in patients who have isolated traumatic brain injury. And this echo-based finding is related to the severity of traumatic brain injury. So the brain-heart connections are really important. Now, why is this relevant? Because if we know that the heart is affected in traumatic brain injury, then the medications that we use to treat hypotension or low blood pressure after TBI may need to consider cardiac function as opposed to what we thought before, which is use a variety of different drugs. And as a cardiologist, we know that different medications have different profiles.
That's fascinating, because as I said, when people have heart attack, we have the same situation where there's no blood supply to the heart and where time is critical, and also perfusion, which is the amount of blood that is flowing through. So you're saying that there was not much research information or guidelines available for, how you need to treat these patients with the trauma to the brain.
That's correct. And in 2012, the Brain Trauma Foundation published a series of guidelines, and I sat on that working group. And this group defined what should, based on best available evidence, what should be the optimal cerebral perfusion pressure or blood pressure to the brain in injured children who have TBI. And it seems to be that the blood pressure really plays an important role. And then there is a number, and we should maintain cerebral perfusion pressure over 40 millimeters of mercury. Now, of course, that implies that you need to be treated at a center that has intracranial pressure monitoring, so you can calculate cerebral perfusion pressure.
You're talking about the heart maintaining the blood pressure, but by the same token, as you mentioned earlier, it's the brain that maintains the heart and the circulatory system to maintain the blood pressure. So it's like a two-way street where you're expecting a traumatic brain to function normally to maintain blood pressure so that it gets adequate blood supply. It's a very challenging situation.
Yes, absolutely.
Okay, let's talk about what are some of the most common causes of brain injury.
So in children under the age of 1, we think about congenital malformations and sudden infant death syndrome and things like that. But in fact, between the ages of 1-year-old and 44 years of age, injury and violence is the leading cause of death in the United States. And traumatic brain injury is the leading cause of injuries in that perspective. And if you look at the mechanisms of traumatic brain injury, the leading cause is actually falls. It used to be motor vehicle crashes until a few years ago, when the population in the United States started aging. And so now we have a large number of over 65-year-old patients who are on blood thinners, for example, for other problems.
All cardiologists' fault.
That's correct. Well, I have to agree. No, I'm kidding. Cardiologists are very important.
We are the ones who give blood thinners.
That's right. And there are no really great blood thinners.
That's the thing, yes. I have seen all of this. People falling, having hip fractures, and we have to go and clear them for surgery and all these things. And of course, bleeding in the brain, which can lead to stroke.
And in fact, many elderly patients have ground level falls. They just trip
That's
at
right,
home.
yes.
It's not like they're climbing ladders and they're falling. I mean, that happens too. But a lot of elderly patients have really poor outcomes because they fall while on blood thinners, and they don't get early correction of their bleeding from the blood thinners when they hit the hospital. So we have in the state of Washington implemented a rapid reversal protocol. So patients who are on Coumadin, for example, blood thinners, will receive something called FFP early, within the first few hours after admission, once their head CT scan shows an injury. And that, we think, will actually improve their long-term outcomes. So falls is a big problem. Motor vehicle crashes still remains problematic because people drive without their seatbelts, they drive too fast, they drive drunk. And in fact, in states of Washington, like Washington, we're now concerned about the effect of legalizing marijuana, which may add yet another dimension to the motor vehicle crash burden that patients have.
That's amazing. Ladies and gentlemen, you are listening to All India Radio Houston, and my special guest is Dr. Monica Vavilala, who is an expert on traumatic brain injury, especially among children. And if you'd like to join in the conversation, if you have any questions, give us a call at 281-983-9550. And brain injury among children is a very important topic, especially if you have children. This is an important topic because brain injury can happen at any level of trauma, which may be even very trivial at the time when it happens, but it can have long-lasting repercussions. Okay, let's talk about somebody comes to the hospital with a traumatic brain injury. How do you approach these patients, and how do you stabilize and manage them?
The evaluation and treatment strategies obviously vary by severity. So if patients are awake and alert, talking to you, but they may have had a loss of consciousness, they probably fit into the mild traumatic brain injury category. Even those patients we're starting to learn have long-term consequences. It may not be as obvious. For example, those patients may have memory changes or personality changes, irritability, mood swings. Now, we can't blame all of mood swings on a TBI, but I think it's worth thinking about even that minor bump on the head. Now, there used to be a practice where all patients all children in particular, who have a history of traumatic brain injury get a CT scan. That practice has largely changed based on some very strong evidence by a leading researcher named Nate Cooperman, who published some very important studies in The Lancet showing that there needs to be strict criteria for imaging. This is because CT scans are not benign. If done not using pediatric imaging protocols, or if done using frequently, they impart ionizing radiation. And so there is an increased lifetime attributable risk of cancer if you image people when they don't need it. So we have sort of scaled back and really become very thoughtful about how do you diagnose TBI or in patients who seem well in the emergency department. Now, if patients don't have a loss of consciousness and are able to, interact appropriately, then those patients are sent home. If patients have an abnormality on their head CT scan, for example, or are not responding to questions appropriately, they may be hospitalized for further observation, because even that small bleed in the head can increase over time. Now, of course, if you have a patient who is unarousable, that is, can't respond to you, those patients may need more monitoring to figure out how best to reduce the TBI burden, or and sometimes those patients need surgery for evacuation or removal of a blood clot in the brain. And those patients are also very sick. So the hospitalized patients are a different group than the patients who may play football, for example, and have a concussion, or the patient who's playing soccer and have a concussion, who may be released to go home.
These patients who are having a more severe brain trauma with loss of consciousness and maybe some trauma to the brain, do they need to be in a special hospital, and do they need to be transferred immediately?
This is a very contentious. This is a contentious issue because there's the reality of how hospitals practice medicine. and that has to be balanced against what we think is best
Best
for
for the
patients.
patient, yes.
So I will say that as a person in academic medicine, I can
Yeah.
probably get away with making the following statement, which is hospitals are often designated as certain
Yeah.
levels of trauma centers.
Yeah.
And we have a level 1 trauma center here in Houston. The University of Texas Medical School in
That's-
Houston,
yeah.
which is where I went to school, is a level 1
Yeah.
a trauma center. And the reason that the designations are important is because there's infrastructure to support
Yeah.
rapid evaluation, evidence-based treatment, and outcome follow-up of these types of patients. So I would argue that if you have a very severe TBI, that you should receive care at a facility that is properly staffed by
Yeah.
physicians with particular expertise, and to have, importantly, the links to rehabilitation care that these
Yeah.
patients often require.
So the people at the peripheral hospitals who are supposed to be educated to know which patient needs to be transferred versus which can be managed in a local hospital, how do we educate these people as to understand, what kind of trauma needs a much higher level of care?
We have learned over the years that education provides part of the
Yeah.
solution. I think we appeal to the sense of right and wrong and goodness for patients.
Yeah.
The reality is that we also have to get around policy, and this is where organizations such as medical
Yeah.
associations or state task forces on trauma
Yeah.
care, or the institutes like mine, which is the Injury Prevention and Research Center,
Yeah.
inform public policy.
Yeah.
We go out and present data on outcomes
Yeah.
based on where patients receive care.
Yeah.
And once we're able to make that case, then it's very hard to refute or argue that if you, for example, you're a cardiologist,
Yeah.
I could ask the same question. Should every hospital be
Yeah.
conducting open heart surgery? Should there be a critical volume
Yes.
that those hospitals see?
That is true, yes.
And there are papers published that show that outcomes are better when patients with certain conditions receive care at hospitals who take care of a critical number, a
Yes.
certain number, what we call trauma volume
Yes.
in trauma care. So trauma centers, in general, have better outcomes than non-trauma centers.
Yes. Ladies and gentlemen, you are listening to All India Radio Houston. I am Dr. Nik Nikam, and my special guest is Dr. Monica Vavilala. She is an expert on traumatic brain injury, especially among children, and we are talking about how to minimize brain injury and return these children back to full activities. And if you'd like to join in the conversation, the number to call here is 281-983-9550. I would also take a moment to talk about Bollywood Blast, which is going to be on August 31st at Miller Theatre, and you can contact Samskriti Houston at 832-275-9656. And also don't forget, Hindus of Greater Houston, they are bringing Janmashtami on August 23rd, 2014 at 6 p.m. at George R. Brown Convention Center. And today at 7 p.m. at the India House, you can go and laugh, listen to poetry, and have a wonderful evening with Kumar Vishwas, which is brought to you by the folks at India House and also the Hindi societies. So we are talking about traumatic brain injury to children and how best we can minimize that so let us, my special guest is Monica Vavilala from Seattle, Washington, Harborview Medical Center. What are the things that you have learned from your research, and what are the things that you have been able to implement at your hospital, at the state level, or maybe at the national level in terms of minimizing the trauma to the brain after an injury?
That's a big question. So I've been working in this area for about 20 years.
Yeah.
And I've learned a lot over this course, including the fact that it takes a long time for research to translate into practice. About 17 years. So it is only now that I'm starting to see the effects of the work that I've been doing. I suppose one of the first impact that our work has had is in increasing the awareness about radiation dose exposure
I see, yeah.
to children who have TBI who receive head CT scans. We began a series of projects. We had some findings that showed variation between hospitals in
Yeah.
CT scan protocols. We made presentations to the Department
I
of
see, yeah.
Health. We then contacted our state officials on trauma care
Yeah.
and started working on devising protocols that were
Yeah.
more consistent across our state. So what we've been able to do is increase the amount of thyroid shielding, for example,
Yeah.
that children receive during imaging. So this took a while. We had to first talk to our own hospitals, make
Yes.
sure we were compliant with Image Gently and the ALARA principles that the radiology societies
yes.
work with. And our science teams are pretty large. We work in interdisciplinary teams. We
Yeah.
have all kinds of physicians, and in fact, not just physicians, but we have nurses and policy people at the table so that we can make that translation faster. The other pathway that we've been able to create,
Yeah.
as I mentioned, is making sure that patients with head injury who are on blood thinners receive
yeah.
rapid reversal of that thinning process so
Yes.
that they don't bleed as much in their
Yes.
brain.
Oh, yeah.
We do this all over the state, and that's something that's come out of our center. Most recently, we are starting to develop interdisciplinary care pathways for
Yeah.
our hospitals. And what that means is, from the patient's perspective, which is how
Yeah.
we're supposed to think about healthcare,
Yeah.
we want to make sure that the physicians who are treating these patients have common goals. So
Yes.
things like blood pressure goals, and you're a cardiologist, you'll appreciate this.
Yes.
You may write in your note that a patient should have a blood pressure of X, and you
Yeah.
think that's better. But they leave your unit and they go to another treatment location. And in fact, that may or may not be followed.
Yeah.
Those physicians may not understand it. So we're working with what we call implementation science experts,
Yes,
people
yeah.
who translate practice into behavior, to figure out how best do we work around workflows and
Yeah.
concepts so that everybody's on the same page. So that at the end of the day,
Yeah.
the patient's perspective is preserved regardless of where
Where
they
they go.
receive
Yes,
care.
yeah.
This is a 5-year-long project funded by the National Institutes of Health, and we're now taking the quantitative findings that we have from research and pushing it out into the places where patients receive their health care.
That's fascinating. Ladies and gentlemen, you're listening to Dr. Monica Vavilala about a traumatic brain injury among children, and you're listening to All India Radio on 1090 AM. If you'd like to join in the conversation, the number to call here is 281-983-9550. Let's talk about what is the success rate of recovery among children who have brain injury.
I would say this is largely an unanswered question
Yeah.
and varies by injury severity. Let's take the mild
Yeah.
traumatic brain injury group first, because they actually comprise the majority
Yeah.
of TBI.
Yeah.
There's a lot of debate right now at the level of the Institute of Medicine
Yeah.
and at the NFL and soccer leagues
Yes.
about what do you do when your child gets hit while playing a sport.
Yes.
Most of those children appear to be functioning fine, but they may have poor school performance or they may have mood changes. When should they return to play? What should those guidelines be? This is still very much under discussion. The markers that we have for brain
Yeah.
health, if you will, are rather crude. So there's a lot of funded work at present trying to understand what that recovery profile ought to be. I will say there are a couple of really well done longitudinal studies where children
Yeah.
were recruited from a population base and studied and followed for 2 years after their mild TBI.
Yeah.
And a significant proportion of them still have difficulty at school. So I would say if we're screening, there are a few places we should begin. What does their mood look like, and how are they functioning at school? So even though it's a mild injury and the brain is relatively plastic, in other
Yeah.
words, children are growing, there does seem to be long-term disability at least out to 2 years
Yes.
after TBI. Now, there's some disagreement about how do you restore that. Is
Yeah.
exercise good because it promotes
yeah.
blood flow and you perfuse areas of the brain that may be vulnerable?
Yeah.
That's one line of discussion. The other is, should the brain be at rest?
Yeah.
In other words, should you let it heal? Now, these two treatments are diametrically opposite to each other. we don't quite have the answer to all of this.
I remember, like 20, 30 years ago when people had heart attack, they were put on a bed rest for like 4 to 6 weeks or maybe 2 months, saying that giving rest to the heart will help heal and all these things. Today, you have a heart attack, you get an emergency cardiac catheterization, you get a stent. 2 days later, you go home and they say start doing all your activities.
They say start doing cardiac rehab.
Yeah.
We haven't quite yet defined what brain rehabilitation is. And I think this is an area that is really ripe for investigation.
Well, this is so fascinating, and my brain has been so much engaged, and it's running so fast. I mean, I can't even stop thinking all the questions I want to ask, but I think we got only a couple of more minutes left. I couldn't imagine this went so fast. Tell us, what are the things that you have learned to help parents, teachers, sports educators, in terms of minimizing brain trauma to begin with, because prevention is far better than any type of cure.
This is a great question, and I would say that there's the Centers for Disease Control and Prevention has a website which actually describes in their facts and statistics section what the rates of TBI are by region where you live.
Yeah, I see.
So you can look up the state of Texas, you can look up Washington, etc. And you will see that the rates are not all equal across the country.
I see, yeah.
The South and the Midwest have higher rates than other places. You'll also see that mortality rates vary by where you live.
Yeah.
So you've asked a very good question. You don't want the TBI to occur in the first place. And what makes a difference? Well, I think it's really important to talk about public health.
Yes.
It's important to talk about preventive measures like seatbelt use and booster seat use, and people learning how to use those properly by age and weight, and there are plenty of internet resources where you can learn. Underserved populations are more at risk than the majority population, and these educational pieces are available. So parents should look to those to prevent the injury in the first place. The second is riding a bicycle without a helmet. And some of the foundational work was done at our institute where we showed that if you wear a helmet, you reduce the incidence of traumatic brain injury greatly. That's why Washington was one of the first states to actually implement a bicycle helmet law. Now, in various parts of the country, helmets and seat belts are thought to infringe upon patients' individual liberties.
Oh, gosh.
That is really
I don't know what they want, brain injury or individual liberty.
Well, this is a problem. Motorcycle users don't wear helmets, and they have very severe injuries as well. So I think from a prevention perspective, those are three very important things. The other is screens, window screens. When it's hot weather outside, sometimes people open the windows and they use screens. And parents have a false sense of security that the screen is somehow protective. But they're weaker than windows, and children can easily fall out of screens. And so one has to be very careful. It doesn't substitute for actually making sure you have your eyes on the child.
Absolutely fascinating. Monica, as I said, as a doctor, I'm so engaged into listening to this highly informative and intellectual dialogue. Just tell us how somebody can find a right doctor in Houston if somebody needs help in this field.
Well, I think that the first route is to go to your primary care provider and actually talk about the fact that you've had a traumatic brain injury. And then your primary care provider should be able to triage, that's the purpose, as to what kind of a specialist you need. That's assuming you have a mild injury and you're able to get to a clinic. If you have a severe injury, I would say that patients with severe injuries need to receive care at appropriate trauma centers, which already have built-in processes for appropriate referrals. The TIRR here is a tremendous rehab facility for neurotrauma, for example.
Okay, Monica, that's all the time we have. It's been fascinating. Thank you very much for being on All India Radio Houston. Ladies and gentlemen, that's about our time, and we'll be right back next Saturday at 10 a.m. You're listening to All India Radio on 1090 a.m. My friend is here, so we're going to be switching gears in 1 minute.
Thank you very much.
Okay. I said, I don't know if you're on here, but anyway.